When making decisions about candidates for nerve wrapping, the first group of cases that comes to mind is revision nerve releases, where we're going in and basically peeling scar off of nerve. All of your top complications are going to involve some sort of recurrence of nerve scarring. So employing a anti-scarring barrier to protect that nerve as it heals from this operation and allow it to have restoration of healthy nerve gliding, I think is a key part of treating that type of revision nerve patient. Wrapping radial or ulnar nerves in the setting of distal humerus fractures when they lie directly on the plate can potentially spare a lot of secondary pathology, because nerves that lie on plates, they're exposed to a lot of foreign body reaction from the plate, and there's going to be a capsular adhesion formation around the hardware that will touch the nerve and potentially cause adhesion of the nerve directly to the plate. And across the elbow, we need a lot of nerve motion, and if the nerve is entrapped and impinged and adhesed, that nerve motion will just lead to pain and dysfunction. The other big group of patients I think that really benefit from early protection are patients with crush injuries. One of the key signs that I look for in crush injuries is bruising of the nerve or stripping of the epineurium. When you lose the epineurial barrier, that sets the nerve up for scar-related entrapment syndromes and direct nerve adhesions. Having some protection of the nerve in that setting and employing early active motion protocols to get some gliding within your conduit. These are modern strategies that lead to better outcomes.